Hello, everybody. I, as a president of Palghar Academy of Pediatrics, Dr. Jayashree Deshpande, welcome you all on our monthly CME. There is a knowledge bonanza today with Dr. Aditi Dandavate, Dr. Alka Jadhav Madam, Dr. Anjali Gokarna, Dr. Anuradha Palwankar, and our past president, Dr. Archana Joshi Madam. Wow, all A-listed peoples now. 1st September till 7th September is celebrated as IAP Nutritional Awareness Week. And on this occasion, I am going to recite a small Hindi poem by Shiva Sharma from Himachal Pradesh. बात पते की तुम ना खोना, बात पते की तुम ना खोना, जन आंदोलन लाकर अब
I am doing an
संदेश
elective
सभी तक
under a
यह
pediatric
पहुंचाना,
organization. I was actually planning for USMLE, but I couldn't clear.
पौष्टिक आहार को ढाल बनाकर कुपोषण जड़ से है मिटाना. So this is our theme of Kuposhan Mukta Bharat. And I request Dr. Genevieve Toscano to, as a moderator for the further proceedings of this meeting. Dr. Genevieve is practicing at Virar. We welcome you, Dr. Genevieve, and please take the reins of this online webinar.
Thank you so much, Dr. Jayashree Madam, for the introduction. As you already said and described through the poem, that we all are celebrating this National Nutrition Week, which starts from 1st of September. And the theme of this Nutrition Week is feeding smart right from the start. So we all know that starting is the conception of the baby, and we are talking about all these 1000 days, right, towards the second year birthday of the child. But I think it goes beyond that, right from the early preconception, when the mother is taking healthy nutrition, so that she gets a healthy pregnancy, culminating into the delivery of a healthy baby. Also, as we all know that everybody, all the eminent pediatrician here are practicing in Palghar, and you all must be seeing a double-edged sword of undernutrition, wherein we have malnutrition and obesity and chronic illnesses that are coming up. And Palghar is serving as a bridge of this urban and rural thing, and you all are the torchbearers of this double-edged sword, which you must be facing in the day-to-day practice. So nutrition is very essential, and we need to talk about optimal nutrition, what is optimum and how to go about it. Going further, I am very much happy to introduce Dr. Aditi Dandavate. Dr. Aditi is a pediatrician, young, dynamic, enthusiastic. As we all know, she's been presenting since past. I have personally heard 2-3 sessions topics of Dr. Aditi. She's currently working as an assistant professor in pediatrics in Cooper Hospital. And I have words less to describe her enthusiasm. So welcome, Dr. Aditi, and she'll be presenting on pediatric stroke and a different cause of pediatric stroke. So over to you, Aditi, ma'am.
Thank you so much, Genevieve ma'am, for your kind words. So, without much ado, we'll get to the topic. So, I'll be just sharing my screen over here. So, this is actually, I will just be describing a poster that I had prepared with one of our students, Dr. Venkatesh. So, this is a poster we had made for this rare cause of pediatric stroke. So, we know that when we talk about stroke, we have a thromboembolic, we have a hemorrhagic stroke, we have a vasculitic, but we had a patient in which it was a little more complex. And is my screen visible, ma'am?
Yes.
So I'll just go to our patient. So it is this child, 7-year-old girl. She is a case of Noonan syndrome, actually like a sister syndrome of Turner syndrome. Same features: short stature, webbed neck, low set ears. It is autosomal dominant, but de novo mutations are also present. So she had been previously diagnosed with ventricular septal defect and pulmonary stenosis. So like a TOF physiology, bidirectional shunt was present. So her baseline saturation used to be somewhere around 92 or so. And if she cries, the saturation used to go a little lower, 88, 89. So TOF physiology patient with very little cyanosis at baseline. So the cardiac defect had not been repaired. Genetically, Noonan syndrome had been proven, and she came to us actually with features suggestive of CNS infection, like fever, headache, projectile vomiting, and on examination we found that she does have neck stiffness, meningeal signs are present, brisk reflexes are present, and vitally she was stable. There were no issues apart from this slightly lower saturation on room air, and uh, otherwise there were no issues. And these classic dysmorphic features have been highlighted in this photo. She had ptosis, exophthalmos, webbed neck, short stature, and low set ears. So on CVS examination, we found a grade 5 ejection systolic murmur with thrill, very loud precordium, thin built child, but no previous admissions for CCF, no previous admissions for pneumonias, and she had been planned for closure of the VSD and dilation of the pulmonary artery, but it due to COVID and all, the follow up had been lost. So she came to us with all these features, and then so we did a little like investigations, baseline investigations. We got neutrophilic leukocytosis TLC of 42,000 in the complete blood count, and the blood cultures were, sadly, it was sterile, we couldn't isolate any organism. CRP was positive, and so after ruling out papilledema, we went ahead with a lumbar puncture. uh, that showed us, actually I'm getting some disturbance in the background actually. uh, if it could just be muted, someone is speaking. Okay. So we did a lumbar puncture and we found a very typical features of pyogenic meningitis: 600 neutrophils and high proteins, low sugars, and like sugar in the CSF was 65. Corresponding blood sugar was somewhere around 150 at that time, and we did a echo as well, and that did not show any thromboembolism, vegetations, anything significant. But on we did an imaging and which showed us this first MRI that you can see, 21st March, is showing a brain abscess of around 2 centimeters with significant perilesional edema, and the CSF is also dirty. It is showing signs of ventriculitis. And so we started her on broad spectrum antibiotics like mentioned in the textbook. Since we couldn't isolate an organism from the blood, we started her on ceftriaxone, metronidazole, and vancomycin to have a broad spectrum that would cover most of the organisms and anaerobes as well. So she showed a good response to this, and over the weeks, at 6 weeks, we repeated one MRI and we found that the lesion has shrunken, but the changes are still present. Like lesions had reduced, but the CSF was still showing ventriculitis, and the abscess was still persistent. So we continued the antibiotics. And on 10th week of antibiotic, a very drastic event occurred. Like she developed a fever after being afebrile for nearly 10 weeks, and she had a fever, and then she developed weakness of the right side and Broca's aphasia. And then we, like during the fever, she had been started on hydration, but like when we got this weakness, we immediately realized that this is probably a stroke. So we got an imaging.
CME as the online. That's it.
Uh, yeah, so we started,
Right.
we
Yeah.
got an MRI done. We saw a left frontal lobe infarct,
Okay.
cortical, and
Local.
we had done an angio, and we found a very interesting finding, which was this puff of smoke appearance that is seen in the MR angio, which is suggestive of stenosis of bilateral internal carotids with lot of collateral formation. So that is how the collaterals appear like a puff of smoke, and that is suggestive of something called as moya disease, moya syndrome actually, when associated with other syndromes. So we went back and looked up that what is happening, and then we found out that there is uh, like among the risk factors of moya syndrome, genetic or chromosomal anomalies is one of the risk factors, and the second one is congenital heart disease, especially cyanotic ones. Because of the baseline low saturation, there is formation, there is like proliferation of the tunica media of the vessels, causing occlusion, and because of that there may be formation of collaterals. So retrospectively it also explained why even on 10 weeks of antibiotics the infection was still present. It was taking some time to get resolved. And then in the scan at the 10th week we saw that the abscess and ventriculitis had resolved. The infarct was cortical, so with physiotherapy we started her on aspirin and anticoagulants in the initial period, and she improved after that. She regained her power. And then like our take home messages from this was that when we see a child with congenital heart disease having a stroke, it is mentioned as one of the common findings after 2 years of age especially, then we should also think about moya syndrome. And this is specifically important because there is a risk of recurrence with moya syndrome, and the factors leading to stroke are as simple as anything that causes cerebral vasoconstriction, like fever, dehydration, or even hyperventilation can actually precipitate a stroke in these patients. So what we could have done maybe is that when we did our first MRI on admission, if we like retrospectively it's easy to say, but maybe if an angio had been done at that time, thinking that there is a two risk factors, congenital cyanotic heart disease and a chromosomal anomaly. So if an angio had been done that time, then we would have known that there is a moya, and we could have counseled the parents that this child might have strokes, if like this might happen. So then what else is to be looked for is the like I went through the possible explanation, actually obliterative changes. So what more can be done is that even if we know that moya syndrome is a silent lurker, we can counsel the parents accordingly, and then they can also plan a revascularization surgery in the future, in which there is anastomosis of extracranial and intracranial vessels. So the stenosed part of internal carotid artery is actually bypassed and the perfusion is maintained. So this, if the parents know about this, it's a better chance of them accepting rather than waiting for a stroke to happen and then telling them that this anomaly is present and it may require surgical correction. So, if we look for it actively when there are risk factors, especially if we are doing neuroimaging for some other reason, so it will help counsel the parents accordingly. So this was our patient. Now she is doing well, and her parents are planning to get her revascularization done soon. Right now there is financial constraints, and that is why this title we had given, that puff of smoke, it's like a train which is running in the background leaving trails of smoke, but it's making very little noise, so people won't realize that it is there. So that is why we chose this title, and that this was the case that I wanted to present today. So when we look for pediatric stroke, when we see a child with stroke, we look for the thromboembolism, vasospasm, vasculitis, hemorrhage, but we should also look for structural malformation, that is moya syndrome. It's very rare, but if you have risk factors, then you should keep it in mind. So that was my presentation. Yeah.
Uh, Thank you so much, Aditi ma'am, for this valuable presentation. What we all could learn from you is having a broader multidisciplinary approach to any particular event is absolutely going to help us in taking the case forward. Thank you so much.
Thank you. Thank you, ma'am.
So
Anybody, if they
there
have
are
any
now
questions?
they say that there are, yeah, there are now they say that bleeding problems in this Noonan syndrome. So is
Uh,
this one of the criteria for the development of stroke in this
uh,
patient?
in this patient, actually, we were rather than bleeding, we have found obliterated arteries, like more like a structural change rather than a hemorrhage. It was more like a thrombotic stroke because occlusion of blood supply. So actually, ma'am, what you are saying is that there is in the moya vessels, they are very thin. So if the patient is on anticoagulants, then those vessels have higher risk of hemorrhage. So that is true. So that is why when we gave anticoagulants in the initial period, that is low molecular weight heparin, but we eventually stopped it, that we don't want risk of hemorrhage, but that is more disastrous. That can cause raised ICT and mortality is very high. So in our patient, we didn't see. So other bleeding manifestations, I have not found any literature on that.
Another thing is that we usually give growth hormone in this Noonan syndrome. So is there do you have given this growth hormone as a treatment, and are this a complication of any hormonal changes which are or endocrinal problems which are occurring in
Uh,
this Noonan syndrome?
So short stature, yes, growth hormone is the treatment. So right now we have not given, like she has never received growth hormone because she came in an acute illness and that evaluation has actually not happened. Like even for something like heart disease, which was like an emergency, even that evaluation has not happened. So in pre-pubertal endogenous hormone changes, I am not aware, but we have not given any hormones to her.
So ideally, what are the treatment you advise for this patient? Ideally, because of the money constraint, you are not giving such things to any patient with Noonan syndrome. But ideally, what we should give to these children?
For the short stature, yes, after checking the bone maturity and everything, she can be given a trial of growth hormone therapy. Many times they respond well. Maybe the target height, like a little more than the target height, may be achieved. It may not happen that she suddenly becomes 155, 160 centimeter, but right now she is at 7 years, she is just 102 centimeters. So maybe that potential instead of 130, 135, she may reach say 146 or so. And I'm sure endocrine people would be more equipped to like explain it.
Thank you so much, Aditi. It was
Thank you,
really
ma'am.
interesting. Yeah.
Thank you, ma'am.
Great. Well done, Aditi.
Thank you, ma'am.
Proud of you.
Thank you, ma'am.
We are getting echo also because of what madam has to say is repeated. Madam, छान वाटलं पण तुमचा इको येतोय.
Bye.
Okay.
Uh,
Yes.
Alka ma'am joined us.
Yes, Alka has joined.
Yes, I'm there.
So,
But I
uh,
can't see you all. Can I leave and rejoin the meeting? That's some
Yes.
problem.
Yes,
I'll
Alka. No
leave
problem.
and rejoin again.
Yeah. Okay.
Yeah.
Yeah, till that time, Genevieve, can you introduce Dr.
Yeah, yeah.
Alka, hello, madam? Yeah.
Yeah, ma'am. Yeah. So we all would like to welcome Dr. Alka Madam, Alka Jadhav Madam, and words are short to introduce ma'am. Ma'am is an eminent clinician, academician, and researcher in the field of pediatrics and nutrition. Madam has graduated, Madam has done her MBBS, DCH, DNB Pediatrics, and MD Pediatrics, all from prominent institute, GS Medical College. And more to say that madam has about 20 to 25 publications to her name. To name a few, also a chapter on severe acute malnutrition in IAP textbook of medicine. API textbook of medicine. Madam has also participated in many articles and research publications. Madam is a member of Nutrition Society of India. Madam is a member of Indian Academy of Pediatrics. She's also a member of Liver Foundation. Madam, over to you. The further topic, we would welcome you for this preventive pediatrics pillars of nutrition and preventive pediatrics.
Okay. Very good afternoon.
Good afternoon.
I'm back to my मी माहेरी परत आले आहे आणि मी बऱ्याच प्रमाणात मराठीत बोलणार आहे असं मी डॉक्टर हेमंत जोशींना प्रॉमिस केलंय.
Great,
That
great.
is so nice.
तर am I audible properly?
Yes, yes, madam.
Okay. And can you all see my slides?
Yes, we can see, but we want to see you also.
I don't know how to adjust that.
Okay.
My video is also on, but I don't know. No idea.
No problem, madam. You continue.
One minute. My video, why is it off? Anyway, I think I would like to also, I'll just check once. The video is on. Yeah.
अरे किती दिवसात किती वर्षांना आपल्या घरात डोळ्यांची नजर दिसते आपल्याला 10 वर्ष झाली आपण नजर बघितलीच नाही ना ते बाकी काय नाही आणि ते काय आहे तुझं काय स्टार्टअप मी सध्या इन्व्हेस्टर्स होते अरे त्याची काळजी कशाला करते जेवणात पोल्ट्री माझी बोलून काय करा इन्स्पेक्टर
Sorry. No. Can you all see? I don't know. I only can't see.
Alka, we cannot see your slides now.
I know. One second. I'll
So you please again log out and then join.
log in. I think that
Huh.
will be a better.
Yeah.
I think. Can somebody share the screen? Though I had been to Sion, I actually got it set and came, but there's some problem.
Okay, Pallavi madam, can you please share the slides?
Yes, ma'am.
Visible.
Yes, thank you. Thank you, Pallavi. Dr. Alka, now she
Yeah,
has
I
started
can see.
sharing her slides.
Yeah, can you hear me?
Yes,
Yes.
we can hear
Okay.
you.
Alka ma'am, please
Yes,
tell us
Alka.
when to go ahead.
Yeah. Next. Next. See, as you are aware, आपण असं म्हणतो अन्न हे पूर्ण ब्रह्म, म्हणजे अन्न हेच पूर्ण ब्रह्म आहे. आणि शेवटी आपण कशासाठी, पोटासाठी हे जे काही काम करतो, सगळ्या ऍक्शन्स करतो, ते मानसिक समाधान पण आहे. पण सगळ्यात जास्त म्हणजे आपण असं म्हणतो की विधभर पोटासाठी आपण बऱ्याच ऍक्टिव्हिटीज करतो. तर आपण काय खाल्लं पाहिजे किंवा काय नाही खाल्लं पाहिजे यालाच प्रॉपर न्यूट्रिशन किंवा बॅलन्स डाएट असं म्हणतात. तर कारण पोट भरणं आणि प्रॉपर न्यूट्रिशन घेणं याच्यात खूप फरक आहे. सो इटिंग अ डाएट दॅट प्रोव्हाइड्स बॉडी विथ लॉट ऑफ ऑल द न्यूट्रिएंट्स, विटॅमिन्स, मिनरल्स फॉर इट्स प्रॉपर फंक्शनिंग is something which is called as proper nutrition, also termed as balanced diet. As you are aware, we have our food consists of macronutrients as well as micronutrients. We have studied in our school days about macronutrients. They are carbohydrates, proteins, fats, and water. But we have a lot of micronutrients which are vitamins, minerals, antioxidants, and phytonutrients, and dietary fiber. Next. Next. So this pediatric nutrition is an interesting branch. It's one of the most sidetracked branch. I will not say non-liked branch, but it is a sidetracked branch where people feel, oh, it's not my cup of tea. It is a dietitian's job. Means in fact, when I started doing pediatric nutrition, majority of them, they think that, अरे अभी तो dietitian क्या करेंगे? So I think it's a teamwork. It is divided into therapeutic nutrition and a preventive and promotive nutrition. Therapeutic nutrition is today beyond the purview of my lecture today, but preventive and promotive nutrition, the most important example of prevention and promotive nutrition, one, iodization of the salt, which has prevented lot of mental retardation in iodine deficiency area of goiter. Second preventive nutrition is introduction of folic acid to the periconceptional mothers. that has prevented neural tube defect. Means in fact the neural tube defects have come down to zero in areas where periconceptional folic acid supplementation is practiced. Apart from that, there are a lot of other therapeutic as well as preventive implications of our nutrition. So what do we do? The promotive nutrition actually optimizes the growth and development in infants. And what we have to say, habits are hard to change, you know. So even if you want to change a bit, it is very, very difficult to change your habit. So you have to establish the healthy lifestyle from the preschool years till adolescence. Okay. So this is very, very important from pediatric point of view. So this prevents, so what malnutritions we have. So when you have a healthy nutrition, it will prevent all forms of malnutrition, micronutrient deficiencies, overweight, obesities, and diet related non-communicable diseases in future life. These diet related non-communicable diseases are actually the obesity, overweight, hyperlipidemia, metabolic syndrome, hypertension, and many other. So this is called as DRNCD, or diet related non-communicable diseases. Especially when vaccines have conquered the world, now we have DRNCD coming up. In fact, at Science Hospital, they are planning to start a NCD OPD even for an adolescent age group. So this is NCD, which this is a need of an hour which we need to work. Next. See, our food which we eat is actually divided into 10 food groups. These are cereals and pulses, cereals and millets, pulses, vegetables, nuts and oil, green leafy vegetable, fruits, dairy, roots and tubers, flesh food, and spices and herb, which will not only adds the taste but also gives little antioxidants. Turmeric has a lot of antioxidant properties, and it will also give even mustard, ginger, they have a lot of antioxidants and phytonutrients. So they are our food groups which are there. Next. So of this food group, ideally we are supposed to eat minimum 4 food groups in a day. That is minimum acceptable diet, or it is also called as minimum dietary diversity. So of this 10, at least in a day, a child should eat 4. Now we come to the food pyramid, which involves this food group. So this food pyramid is little different from children and the older adult. See, children food pyramid, if you really go to see, we have cereals down in the bottom. Okay. So these cereals which are down in the bottom, which it's there because children are growing, they need the energy and they need to be really remain energetic all throughout. Versus adults, they have finished their growth spurt. So the adult food group is something where the bottom consists of salads, vegetables, and fruit. Okay. Then that is followed by the cereal, then the milk yogurt, then comes poultry, and really top portion comes is actually the drinks and foods which are high in fat, sugar, and salt. So that is called as HFSS, high fat, sugar, and salt. So this FSS, HFSS, see, the thing is, we have to really, we cannot avoid it all the time, but you have to restrict it. Like, see, high fat, sugar, and salt. For example, in pediatric age group, is chocolates, chips. So you can't say no. I mean, if you say no, it will bounce back. All families, everybody, they have experienced how much children love it. So probably when you can't avoid it, better accept it and accept it in a better way so that you can give them maximum once a week in tiny amounts. Okay. So this is about the children receiving high fat, sugar and salt drinks. Next. So this food pyramid, which I have shown, is from National Institute of Nutrition. So this is fine. The breads, the fruits, the vegetables, everything is fine. But what up in those 10 parts of food groups, what we have forgotten is water. So water is the essential of life. So for a pediatric age group, they should eat somewhere between 5 to 10 years, they should eat at least 1 liter of water. And between 10 to 15 age group, they should eat at least 1.5 liters of water. So plenty of water. Water is also called Jeevan. So it has to be given. Sunlight is another source where we receive vitamin D, and sunlight is also included, where half an hour exposure to sunlight between 10 a.m. to 1 p.m. Okay. And that may be along with that exposure, you may have activities, the physical activities, the PT classes, cycling, running. So that is an important part which will really help make you develop a healthy lifestyle. Next. So how does an Indian food plate looks, or it should be looking? See, whenever you have, this is an adolescent food plate and this is a pediatric food plate. Whatever it is, it's similar. Half of your food or half of your plate should consist of, should be colorful, whether it is green leafy vegetable, it is yellow orange fruits, apple, carrots, whatever it is, it should be, half of it should be occupied by the fibers, antioxidants, veggies, okay, and the remaining half should contain the grains to a 40 to 60% in pediatric age group, 40% in adolescent, and the proteins. And this protein part may come from beans, may come from egg, may come from other protein containing. But contrary to the belief, हमको दूध नहीं पीना है, नहीं पियो, but at least have some curds or chas. So one dairy product has to be there. So this will give you a lot of probiotic also, and it will give you proteins also. So it's a healthy Indian food plate. Next. So this is something which probably you all won't like. How does nutrient prevent diseases and promote health? So there are a lot of things which a nutrition does. One, it enhances immunity, prevents repeated infections. It ensures proper growth, development, especially the cognitive development and brain growth. It also supports and promotes the bone and muscle health. Academic performance is better. The sleep quality is also good. And whenever you have a good sleep, even your mental health remains good. It supports the digestive health with good microbiota and oral health. All other systems, it really keeps it fine. It reduces the risk of metabolic syndrome by improving the insulin resistance, or it reduces this metabolic syndrome risk, which is very, very good, especially when India is going to be the next diabetic capital of world. So it promotes longevity and improves overall the quality of life. Next. So the nutrition, I cannot forget the first 1,000 days of life. In this first 1,000 days, we have a pregnancy, that is preconceptional part. First year, which is 365 days. Second year, another 365 days, making nutrition in first 1,000 days of life. I'm sure a healthy mother gives rise to a healthy baby, and a healthy baby again becomes a healthy mother. So this lifestyle means we want to break that Bacchus hypothesis. So we have to focus on adolescent girls and pre-pregnant mothers so that the baby born is good. start preconceptional folic acid so that we have no problems. Next. Okay, so every stage of life, the balanced diet is required, whether it is exclusive breastfeeding for young infants up to 6 months, complementary, adequate complementary feeding up to 2 years, 2 to 6 years when they are preschool children, adolescents, adults or elder. Every stage, balanced diet is important. Next. So what is essential nutrient action, especially when month of September is declared as Poshan Maha or Poshan month by our Narendra Modi sir? The essential nutrition and nutrition action includes 7 components, and these 7 components I just enumerate. I'm not going to go into the detail. One is optimal breastfeeding practices. Second will be optimal complementary feeding practices with continued breastfeeding along with nutrition care of sick and malnourished children, because care during illness is very, very important. Improving women's nutrition, empowering adolescent girls and improving their nutrition is also important. You have to control vitamin A deficiency, control of anemia and iodine deficiency disorder. This is a government directed program, very well implemented, okay, last 3 years. Next. So these broad dietary guidelines I have taken from NIN, National Institute of Nutrition 2024. Okay, so there are 17 guidelines. I have just copied the heading of these guidelines. So first, eat a variety of food to ensure balanced diet. This means that you have to have a minimum dietary diversity with at least 4 food groups. At least 4 food groups means 5 and beyond are acceptable. So ensure that you provide extra food during pregnancy and lactation. See, during pregnancy, from second trimester onwards, the mother needs around 350 to 400 kilocalories extra as a diet. And during lactation, she needs around 600 to 700 kilocalories extra because she is lactating around a liter of milk. So we have to, and obviously if the mother is well nourished, she will give rise to a good quality of milk. So ensure early initiation of breastfeeding, exclusive breastfeeding for first 6 months and continue breastfeeding for 2 years and beyond. You have to start feeding simple homemade complementary, semi-solid complementary foods to the infant soon after 6 months, not when the 6th month have begun. It is after completion of 6th month. Okay, so we do our Annaprashana ceremony after 6 months completion. So we have to start feeding home-based semi-solid, not watery, remember. Ensure adequate, appropriate diet for children and adolescent age group because they are growing, both during health and diseases. Eat plenty of vegetables and legumes. Your half plate should be veggies and legumes will give you the proteins. Next. What we have is now our proportion of severe malnutrition, though we have stunting which we are not unable to conquer, or what is happening to the level of stunting is actually a chronic lack of calories. So, and once it happens in first 1,000 days of life, it is very difficult to reverse back the stunting. Because if you really go to see, the child gains around 38 centimeter of height between first 2 years, because he's around 50 centimeters at birth and 88 centimeter in the second year. So any growth opportunity which is lost in infancy and in first 2 years of life, it is irreversible to a certain extent. So malnutrition is not the problem nowadays, but obesity is going to be a significant problem. So what they are saying is use oil in moderation and choose variety of oil seeds, nuts, nutri-cereals to meet the daily fat and essential amino acid needs. Okay. Eat good quality proteins. Okay. Avoid obtain essential amino acids through the combination of food combination. We are going to discuss this. But by and large, avoid protein supplements to build muscle masses, especially because when the child comes to you and say that I want to be a sportsman, I am going to the gym, I want to do something, insist on natural availability and improvement in the diet rather than giving the protein supplements. Adopt a healthy lifestyle to prevent overweight obesity. Be physically active, exercise regularly, restrict salt intake, and drink adequate water. Next. So I know they are silly instructions, but I felt I must tell you because consume safe and clean food, adopt appropriate pre-cooking and cooking methods. See, what you eat is important and how it is cooked is also important. Like if it is how it is cooked, we are going to come to the cooking methods subsequently. Minimize the consumption of high HFSS, high fructose salt sugar food, highly processed and ultra processed food. Include nutrient and antioxidant rich food in the diet, both from health and diseases. And always don't believe in the shopkeeper blindly. Read the information on the label to make informed and healthy food choices. Okay. So these are the 17 guidelines which needs to be followed by all of us. Next. Okay, wanted to tell you a little about proteins in the diet. I'm sure legume, non-vegetarian source of proteins, I think they are considered as class 1 protein along with egg protein and the milk protein. So the popularly it is believed that proteins will be made only with the non-vegetarian sources is not true. Even vegans can also meet with the along with the milk, they can meet the recommended daily allowance with appropriate combination of with cereals and legumes like pulses and cereal combination. Consuming high levels of protein supplement powder is not advisable because it gives a lot of sodium. Second thing, it causes, it injures the kidney by giving an extra protein load. So it is really not advisable. If at all one has to use protein supplements in diseases or if really indicated, we have protein supplements available from egg protein, we have milk protein egg supplements, we have whey protein supplements, and we have plant protein supplements from soya and other plants. So plant protein supplements are, though they say they are very, very good, they are very expensive. So use with little caution or use with properly indicated. Next. Little bit about the fat in the diet. Our fat actually consists of, we have 3 types of fatty acids, the saturated fats, the monounsaturated fatty acids, and the polyunsaturated fatty acids. Of these, the saturated fats, cholesterol, other lipids, monounsaturated fatty acids, they all can be synthesized in the liver. But what cannot be synthesized is essential, it's also called as essential fatty acid, omega-3 and omega-6. They are the polyunsaturated fatty acids. So that is the reason why we need to consume these essential fatty acids, because omega-3 and omega-6 are important for the brain growth, cognition, and early development in a child. Means in fact we got a recommendation, I have got a paper to recommend whether routine supplementation of omega-3 and omega-6 is indicated for school going children. I still have to write an answer. The answer is probably no as a part of routine supplementation, but improvement in the diet is something which is required if to have it properly supplied. So what are trans fats? We have to avoid trans fats. Trans fats are, you cannot use the oil which is, once you have cooked once, you cannot really use it because it generates a lot of trans fats which are harmful to your body. Okay, now what we have is we have a lot of oils in the market. One is refined oil, the filtered oil, the crude oil is also it's also called the filtered oil, refined oil. We have virgin oil and the cold pressed oil. So this virgin oils or the cold pressed oil are little better version than the crude oil. They are they are expensive, but their antioxidants and phytonutrients are preserved. Refined oil has an advantage that it is pure, but the properties of antioxidants are little less. But now the government has made the recommendation that they should be supplemented with vitamin A and vitamin D. So every oil has its own pros and cons. By and large, the filtered oil is better than the refined oil, and virgins and cold pressed oils are still, if you can afford it, definitely use it. So this is something, but apart from that, this is a visible fat. We have a lot of invisible fats. So this omega-6 is commonly found in walnut. Walnut is akrod. Fenugreek is methi, soybean, mustard, and flax seeds. So our thing that we are using mustard before preparing any food item, it's a good thing that it gives a lot of omega-6 to the, so it gives us, meets our daily requirement. Fish and eggs are also good source of long chain polyunsaturated fatty acid, especially DHA and EPA. So what we have to say probably about the fats in the diet, that about the oil, I think safflower oil, the sunflower oil, they are good. Even filtered groundnut oil is good. Sesame oil is also called as queen of all the oils. So instead of using one oil, it is better to rotate the oil so that once you say you keep 2 oil cans, use 1 can in the morning and 1 can in the evening. That is one way. Or use the mixed oils like rice bran along with soybean oil. So maybe it's something like polypack, which we use it will be really useful. Next. What I want to introduce you to the concept of microgreens. All of you are aware that what are microgreens? Microgreens are actually the tender plants, which has 3 or 4 leaves. तुमच्याकडे नवरात्र किती लोकांना माहिती आहे? तर नवरात्रीमध्ये आपण रुजवण घालतो म्हणजे पहिल्या दिवशी रुजवण घालतो, ते रुजतं आणि 7व्या किंवा 8व्या दिवशी ते वर येतं. तर ते जे रुजवण घातलेल्या, त्यानंतर त्या घातलेल्या रुजवणाची आपण भाजी बनवतो. आणि ते रुजवण म्हणजे वेगवेगळे असे पल्सेस आणि बीन्सचं कॉम्बिनेशन असतं. म्हणजे मसूर आहे, चवळी आहे, असे वेगवेगळे पल्सेस आणि बीन्सचं कॉम्बिनेशन असतं. किंवा बाजारात बाळ मेथी किंवा छोटी बारीक मेथीची भाजी मिळते. So this is something called the microgreens. Either you can make it in the house. It is very good source of antioxidants, phytonutrients, and phytochemicals. So one uses it. If we cannot use it, आपल्या भारतीय पद्धतीमध्ये पोह्यांवर खोबरं आणि कोथिंबीर टाकून द्यायची पद्धत आहे. बरोबर, म्हणजे ते आहे हे रॉ आहे. मायक्रोग्रीन हॅज टू बी इटन रॉ. तर व्यवस्थित धुतलेली आणि चिरलेली कोथिंबीर जर एखाद्या भाजीमध्ये किंवा असं पद्धत आपण सुरू ठेवली, आपली जी जुनी पद्धत आहे, तरी सुद्धा इट विल गिव्ह अस लॉट ऑफ अँटीऑक्सिडंट्स. आणि तसंच गोष्ट आहे स्प्राउट्सची. स्प्राउट्समध्ये बऱ्याच वेळा 3 पदार्थांचे म्हणजे मूग, मटकी, चवळी आणि चणा यांचे जे स्प्राउट्स आहेत ते स्प्राउट्स करून जे स्प्राउट्स सकाळी नुसते ब्रेकफास्ट बरोबर खायला दिले तर इट विल गिव्ह यू लॉट ऑफ अँटीऑक्सिडंट्स फॉर अ डे. Okay, but this microgreens can be very well made at home and can be practiced. So this is something called a accepted kitchen gardening. Okay, next. So what we have to do is something called a healthy eating habit. सांगितल्याप्रमाणे एकदा सवय झाली की सवय बदलणं खूप कठीण असतं. म्हणजे इच्छा बदलू शकत नाही असं नाही, पण बदलली जात नाही, कारण जिभेला त्याची सवय झालेली असते त्या चवीची, आणि त्याच्यामुळे खूप कठीण जातं. म्हणून लहानपणापासून आपल्याला चांगल्या सवयी जोपासणं हे खूप जरुरी आहे. तर एक्सेप्ट ब्रेस्ट मिल्क, actually no, there is no single food that will provide all the necessary nutrients. So what we have to obtain this, to make this balanced diet complete, or to have really the balanced diet, we need to have something that we have already discussed: the minimum dietary diversity and a minimum acceptable diet. Okay, in that minimum dietary diversity, it is minimum 4 groups have to be eaten in a day, and minimal acceptable diet is at least 3 diets should be eaten. So this is frequency wise. The cereal based diet should be accompanied by the pulse or beans combination. म्हणजे आपल्या महाराष्ट्रात मग ते आपण वरण भात असेल, इडली सांबार असेल, सांबार भात असेल, किंवा गुजरातीमध्ये डाळ ढोकळी असेल. सो इट इज अ कॉम्बिनेशन ऑफ सिरियल अलॉंग विथ पल्सेस. मग त्यात ती पुरणपोळी सुद्धा इट्स अ सिरियल अलॉंग विथ पल्सेस. सो बेसनचा लाडू आहे, वेर यू हॅव रवा अँड बेसन along with. So we have lot of varieties which we can give as cereal pulse combination. Always try to include non-starchy vegetable, that is, so vegetable, batata we are not counting as vegetable. So, and give at least 30 gram of fruits. So our elders say that 1 apple a day keeps doctor away is really true. Use adequate quantities of nuts, oil seeds and or fish. तर ह्याच्यात हे जे आहे ते महाराष्ट्रीयन नॉन व्हेजिटेरियन डाएट, इट विल डेफिनेटली गिव्ह यू लॉट ऑफ proteins along with the omega-3, omega-6. But vegetarian diets, we have to have, बऱ्याच घरांमध्ये भाजीमध्ये खोबरं टाकतात, तर खोबऱ्याच्या बरोबर इफ यू कॅन रिअली मेक इट एज शेंगदाणा अलॉंग विथ तीळ अँड अलॉंग विथ अळशी, म्हणजे शेंगदाणा, तीळ आणि अळशी यांची पूड करून ती भाजीमध्ये वरती जर फिरवून टाकली, म्हणजे तर ते नुसत्या शेंगदाण्याच्या कुटाबरोबर पेक्षा जास्त पौष्टिक आहे. एक भाग शेंगदाणा, एक भाग अळशी आणि एक भाग तीळ. हे सो इट विल गिव्ह यू लॉट ॲडिक्वेट इसेन्शियल फॅटी ऍसिड्स अँड omega-3 ऍसिड्स. ओके, नेक्स्ट. So it's now henceforth it is just a pictorial pediatrics. I'm not going to discuss, but it's just to reinforce. Okay, so a 6 to 8 months old child should have at continue breastfeeding, but should have at least 2 foods which he will be eating, of which one will be rice dal or khichdi or papaya or whatever you decide, but it will be around 2 to 3 foods in addition to breast milk. Next. This is the timetable given by Government of India. It's not my own. So the 3 snacks between 6 to 8 months, mid-morning, afternoon and evening with the timetable, and along with this continue breastfeeding. Next. Then we have that between 9 to 12 months, actually they will have 3 major feed and the breastfeeding, 2 minor feeds. Okay. So 3 major, 2 minor, and we continue with the breastfeeding. So total is around 720 kilocalories and proteins of 1 to 1.5 grams per kg. Okay. Next. So this is the timetable again given with 3 major meals between 9 to 12 months old child. Next. Now we come to more than 1 to 3 years or 1 to 5 years, up to 5-year-old child. Obviously, he is energetic, active, so he must drink a glass of milk around 200 ml in the morning. Should have some good breakfast, lunch, again a glass of milk in the evening, should have a dinner, and also should have 2 snacks in between. His lunch or every part of his breakfast should have 1 fruit along with. So he's receiving a fruit, he's receiving vegetables, and he's receiving the variety of food. So you can really see at least 5 to 6 food groups in a day along with the milk he's having. He will be energetic and active. Around 36 grams of proteins on an average, so around 1.5 to 2 grams per kg. Next. So these are the few examples how you can feed a young child. So one is grated mixed vegetable, means how to give that. You can grate the vegetable, mix it, you can add little ghee to it and the child can eat it. You can have plain dalia, boiled egg. What I wanted to tell you is something called eggnog. Eggnog is egg mixed with the milk, but you have to really stir it well so that it becomes more like milk where the child can drink in the morning. So that will be up along with glass of milk, you can give the eggnog. Okay. Next. So this is little school going children. Obviously, they will definitely have, but don't forget milk to be given 2 times a day. That unless they have a milk allergy, those who have a milk allergy will receive buttermilk or a soy milk, whatever. Fine. Next. Again, about 10 years, see the breakfast, milk along with lot of GLVs and yellow orange. So lot of sprouts, the beans. Okay. But the lunch is consisting of at least 4 or 5 food group. You have a fish, you have salads, you have veggies, chapati, dal, okay, and custard, curd along with. So this is something which you have to, so you have to have small amounts, but a variety rather than having 1 or 2 food groups. So it's easy to say, difficult to prepare, especially when you are working woman and you have a less limited household work help. Next. Okay, so this is the adolescents and pre-adolescent age group. To have a good, apart from the activities, your green food plate and the beans food plate. Okay, next. So what you can do, this is something which you cannot avoid. I also have grandchildren and see the friends, they have pasta, they have pizza, they have burger, they have cakes, donuts, and you cannot avoid them. Whatever you have to tell them, you cannot get away with it. So probably and this I have spoken to our dietitian, what do I tell in the crowd? So obviously what we can say is, supposing your child, obviously she will demand Maggie as one of the evening breakfast. So you can have the oats Maggie, you can have the vegetable Maggie with whole wheat Maggie, you can have ragi Maggie, which are available in the market. And whenever you're cooking the Maggie, you can add little sprouts to it, you can add little kanda and tomato, so that at least, you can make it more nutritious as well as delicious. So this is something called which you can swap the food. So foods with a high calorie and sugar, you can have more sprouts with and salads with less calories. Fried food should be replaced with the baked food. High sugar content should be replaced with the help of low sugar content. Fruit juices should be replaced by fruits, because they will give you fibers and antioxidants. Your artificial juices like Thumbs Up, Fanta, Mangola, they should be replaced by natural sugarcane juice. You may have coconut juice, you have curds, lassi. So Nimbu Sharbat also is good enough. Then tomato sauce and jams and all should be replaced by homemade chutneys. Though I know, easy to say, it is very, very difficult to convince a child to do it. But try, keep on trying, maybe it will still change. Next. So this is an activity table. How much activity you should have. See, aerobic, that is brisk walking, is minimum 20 minutes. Other physical activity like regular walking is 60 minutes. And then you can see the screen time should not be more than 2 hours, because that screen time, eating and personal care. So screen time should not be any day more than 2 hours. Okay. And have a good sleep, which is very important. Next. So restrict salt in any form. It's not good, whether you want to use black salt, low sodium salt, regular salt, iodized salt, but always restrict their use. It will prevent the obesity related complications. Next. Now we come to, you have to wash the vegetables before cutting it, and don't wash it after cutting it. Okay, so wash it properly. Next. So now we come to little do's and don'ts. I've already told you, so I'm not going to repeat, but avoid the sugary juices, avoid the stored or canned juices, consume the fresh, either lassi. Even if you want to eat lassi, consume the fresh lassi, the lemon juice, coconut water, the fresh fruit juice, rather than canned juices. Next. Next. Okay. Try to give milk to the child, avoid tea, avoid chips, fried foods. Okay. Next. Sugar is not good. So avoid or restrict sugar content, whether it is jaggery, whether it is chicky, whether it is cake, or in any form. Next. And no sugar to be added to a child less than 2 years. Okay. So this is about restrict or avoid the fruit juices. Next. Now we come to, when we are classifying the food items, we put them as group A food, which is supposed to be one of the best foods, which are freshly cooked food at home, good quality grains, they are not polished, not stored, and we will really try to restrict our food to a group A food diet. Next. Then what we have is a group B food. In this group B food, there are little processed food. Examples of group B food is polished rice. You have maida. Then you have refined wheat flour or polished millets. So though they are expensive, they are not good. So another example of these group B foods is uh, pickles, then sun-dried papads, sweets, chips. So though they are good, but try to restrict this good group B food because it has an altered nutrition composition. Next. Then we have the group C food, and in this group C food is processed, ultra processed food. See, remember bread, cakes, chips, biscuits, fries, mayonnaise, sauces, they all are a group C foods. Even the commercial ice creams, the protein powder, the peanut butter, they all are group C foods. So they have the ingredients which are stored in them. Like they have the processing, they are the processed foods. So they have additives, they have coloring agent, they have flavoring agent. So definitely try to avoid group C food. As far as possible, try to restrict your diet to group A and group B foods. Okay, next. Read the nutrition facts very carefully, what is given. Like when you are taking an insurance policy, they always say, read the document carefully before signing. It's the same way, read the nutrition facts carefully before you consume and see that you have an FSSAI logo on it with veg and non-veg food. Okay, next. So what is, see, whenever we speak about nutrition, now ultimately you say that we are doctors. The child will come to us and we are going to examine the child. So how will I know how is he nutritionally? So this is something called ABCD of nutrition assessment, where A stands for anthropometry, B for bioclinical assessment, C biochemical assessment, C is for clinical assessment, and D is diet recall or history taking. Okay. Anthropometry is the measurement of the size and the body proportion. Remember, prevention is better than cure. A stitch in time saves 9. You catch these children early and institute a behavior change. Maybe it may not be visible, but it will definitely be there, sure shot, and things will really improve over a period of time. So every child entering into your clinic must undergo the nutrition assessment, anthropometry, dietary, and we'll come to it about the screening test or the scans. Next. So in anthropometry, you must have the length, which is or the height. Then you have to take the weight of the child, mid upper arm circumference, head circumference, waist circumference, and waist hip ratio. See, waist hip ratio, waist height ratio, and body mass index you are supposed to calculate. So the interpretation of this anthropometry is beyond my discussion point today. But every child must undergo this anthropometry very meticulously. Next. Age appropriate anthropometry. And accordingly, we have the Indian Academy of Pediatrics, the waist circumference chart. For example, I've just given it pictorially. We have a waist circumference chart. So if you really don't have a waist hip ratio or waist height ratio calculation, but plain simple mid-arm circumference for severe acute malnutrition and waist circumference for overweight obesity is also good enough to pick them early. Okay. So we have a BMI chart beyond the age of 5 years. We have a waist circumference chart by Dr. Khadilkar beyond the age of 5 years. So up to 5 years, still in India today, weight for age above 85th percentile is taken as, since we do not have the charts available, is taken as suspicion of overweight and obesity. So overweight is above 85th percentile and obese is weight for age more than 97th percentile in children less than 5 years. Okay, next. So what has not been changing is underweight is child who is less than 5th percentile. Healthy weight is 5th to 85th percentile. Overweight is 85 to 95th percentile. And obesity is 95th percentile and beyond. So this is something which probably one has to remember. So this is easier to do it if you train your anthropometry nurse. I think you should be able to do it. The obesity ratio calculation, though they are accurate, I think restrict it to waist circumference in your clinical practice, it will be really good. Next. So there's something called, we do the clinical examination where we do the general examination, we do the systemic examination. Aditi Dandavate has already spoken about the neurological examination and other things. But what is missing in the examination is something called nutrition focused physical examination. And this is something, if once your eyes know and you are aware, you will look at the child. So obviously the nutrition focused physical examination, first you assessment of the body fat, you will look for visible severe wasting, where you will look at fats in the orbital region, the upper arms, the hips, intercostal area. So that visible severe wasting, you will definitely look at the child. खूप बारीक दिसतो is a layman's term, but you will definitely look at the assessment of the body fat. Then you will look at is the assessment of the muscle loss. And in this, you will definitely have a look at the clavicle, the calf, the arms, and the temple region. Look at the edema of over both the feet for severe acute malnutrition. Don't forget to hold the hand to see whether how is the hand grip. If the child is weak, obviously, even in absence of any neurological illness, his hand grip will be weak. And fifth, look for the specific micronutrient and vitamin deficiencies by using the Aspen chart. Okay. So Aspen is American Society of Pediatric Enteral and Parenteral Nutrition. They have come out with the chart so that can be practiced even by the paramedical worker to know whether the child has a suspected nutritional deficiency or not. I've just given you the photos of the chart. I could not really get the printout of the chart, otherwise I would have uploaded that. So I've taken the printout from the, I've taken the photos of the chart. Okay, next. So if you really go to see, you look at the fat loss over the orbital, buccal, upper arm, ribs, and buttocks. Next. Then you look at the muscle loss over the temporal region, the clavicle, the acromion bone, over the patellar region, anterior thigh, and the calf. So you really have a holistic look at the child. Next. Next. Then you look at the hand grip. You look at the fluid accumulation as a part of pitting edema. Mid upper arm circumference measurement is definitely there, and the arm span measurement is also to be noted. Next. Then skin, what all things you will look at the skin. Look at the petechiae, dermatitis, necklace dermatitis, flaky paint dermatitis. Look at acanthosis nigricans for vitamin deficiency, xerosis, pallor, hirsutism, non-healing wounds. Next, so thorough skin examination. Next. Then look at the hairs where they are really dry, sparse hairs. Do they have lanugo hairs? Look at the eyes for changes of vitamin A deficiency. Next. Look at the oral cavity, the ulcers, gingival region, the spongy bleeding gums. So, stomatitis. Next. Look at the throat for enlarged, look at the enlarged parotids and look at the enlarged thyroid gland, Next. So apart from that, you look at the other micronutrient deficiencies, hypopigmentation of the patch, the kinky hair, or zinc deficiency gives rise to dermatitis, perianal excoriation. So this is the final part of this Aspen chart. Next. So these are few pictures of the deficiency disorders where you can have costochondral junction. The central child is a stunted child compared to the child in the same age group. They are all severely wasted children. Okay. But they are still alert, looking around, asking for food. Next. Look at the overweight, obese child. Actually, with the little percentile charts, though this is not this is a WHO chart and not the IAP chart. So this is about, it is predicted that by 2025 there will be 17 million obese children in India. So always catch them early and prevent, because childhood obesity is different from adult obesity, because we have the adipocytes not only in size but also in number, because during growing phase the children, the adipocytes also multiplies. So in adults the adipocytes only increase in size, but in children they multiply as well as increase in size. So we really have to work on it. So you all will really wonder, I have always worked on children with severe acute malnutrition. I used to run the childhood obesity clinic with implementation of the obesity management program even at Saina Hospital. So, but today is the time where we need to focus more on childhood obesity so that we catch them early and prevent the diet related non-communicable diseases. Next. So nothing, though I have told you a number of times, probably nothing we really have to say what will bring about the behavior change. Ultimately the family has to adopt the diet, because the practices of the family needs to be changed. So nutrition counseling, repeated counseling, home visits, so that is the key to have the behavior change in the community, in the family and the society. We need to enhance the motivation of the mother. We has to enhance the motivation of the child. See, the mother will always say, हा मुलगा माझा ऐकतच नाही, आणि हा मुलगा सांगेल आई बनवत नाही, मग मी काय करणार. So we have to understand the problem. It is not easy. It requires lot of environmental and social support. Next. So thank you. I have little 2-3 take home messages for you. Is food habits of the urban society is changing. So we really have to adopt to their changing food habits. We have to salute or respect the working mother, and accordingly we have to give them the diet plan, because see, mother may not have time to cook food. So this is something where pizzas, pastas, little processed food is going to stay. So we have to teach them to make how to make the healthier choices, so that children are benefited with the community benefit at large. I really thank Dr. Jayashree Deshpande and Dr. Archana Joshi for giving me an opportunity to speak on this topic. I don't know whether I've given you something new to, probably it's the same thing what we know. I have reinforced, or maybe I've told you the same things again so that you can think it over. And another thing which to prevent anemia, we need to have simple cooking tips like cook on the slow gas and cook in the iron kadai vessel. I think that will really prevent the anemia rather than giving injection ferrous carboxymaltose to all anemic children. It is better to adopt this behavior so that the family is benefited by cooking in iron kadai. Okay. Thank you so much for patient listening. I'm open to
Thank-
questions and
Thank
open
you,
to your
Alka.
suggestions also.
थँक्यू सो मच मॅम. आपण सांगितल्याप्रमाणे आम्ही फ्युचर ऑफ पिडियाट्रिक लाईज इन प्रिव्हेंटिव्ह पिडियाट्रिक्स, अर्ली इंटरव्हेन्शन आणि फॅमिली सेंटर्ड अप्रोच. मॅम एक क्वेश्चन आहे. मॅम तुम्हाला ऐकायला येतंय?
हो, येते येते.
6 महिन्यानंतर ना सम ऑफ द पेरेंट्स दे आर आस्किंग की ब्राऊन राईस म्हणजे जेव्हा सिरियल चालू करतात तेव्हा ब्राऊन राईस इंट्रोड्यूस केलेलं चांगलं असणार की नाही. सो ब्राऊन
Yeah.
राईस मध्ये ब्रॅन
See,
digestion
the brown rice is good, but it's mainly actually it is good because it contains the nutrients which are preserved. But it is better to start with the red rice. Red rice is better than the brown rice because brown rice is mainly the diabetics use it because it has a lot of cooking like it remains खूप मी स्वतः यूज केले खूप कडक राहतो. So it is not easy. But red rice is actually a raw red rice and it has a cooking potential which is very good. So it can be used with red rice. So it is group A category, unpolished rice. So start with unpolished rice. Brown rice is still artificial rice. That's why.
आणि रॉक सॉल्ट बद्दल सुद्धा म्हणजे 1 वर्षापर्यंत तरी ते लोक पेरेंट्स दे डोंट गिव्ह सॉल्ट बिकॉज दे आर वेल अवेअर नाव. पण 1 वर्षानंतर जेव्हा बरेच पेरेंट्स इंट्रोड्यूस करतायत ते लोक रॉक सॉल्ट आता कारण खूप सारे ऍडव्हर्टाइजमेंट्स येत आहेत. रॉक सॉल्ट इज लिटल लो ऑन आयोडीन. तर मग त्याच्याबद्दल कसं म्हणजे काय आपण त्यांना
It's better to give a regular salt than a rock salt because then rock salt they can put it occasionally on some chips, some things which they eat, but regular iodized salt is good enough. Okay, no need to put that's why I showed you the pink salt or they
Pink salt,
categorize
yes.
it as low sodium salt for hypertension but it has more potassium.
ओके.
If it has less sodium salt, then it has more potassium. So better to give a regular iodized salt and rock salt means once or twice a week occasionally.
ओके.
About the sport drink, I wanted to tell you. They always they had advertisement about the sports drink that Gatorade and other health promoting drink. It is better to give the homemade say plain coconut water or homemade limbu sharbat than a sport drink. It's very costly but not cost effective per se. But sports drink will be better than drinking Fanta, Coca-Cola and Thumbs Up. That will be better, but it is more of ORS and ORS related activities. I was on one of the nutrition committee where they said that will you advise regular use of sports drink for athletes? The answer is regular use no, but they can carry enough water or enough lemon juice so that they can use it.
अँड व्हॉट अबाउट दिस प्रोटीन बार्स म्हणजे हे 12-13 वर्षाची मुलं ऍथलेटिक्स करतात किंवा स्पोर्ट्स मध्ये असतात तर ते लोक प्रोटीन बार्स कंझ्युम करू शकतात जे आपल्याला रेग्युलर.
That's what they're saying. See, the national these are NIN 2024 guidelines because nowadays everybody is becoming so aware right from a child that they want to have a Horlicks baby till they're saying that if you are really one thing is there how exercises is doing as an athlete between 12 to 14 years of age. They are not supposed to be gymming anyway between less than 15 years.
Yes.
So going to regular gym and muscle building is not the thing. But if diet can consume, then the milk, then they can have eggs, then they can. But if or the pulses or the sprouts, if they can give, it will be really good, because see, those protein bars give anywhere between 8 to 15 grams of protein. So it is almost, see, if you have a smaller protein bar, it gives you almost a protein equivalent to one egg can give. One egg gives 6 grams of proteins.
Yes.
Or a handful of, he can eat badam, he can eat singdana. That will give the similar fistful, similar thing. So routinely, no, once in a while, once or twice a day, or twice a week or something, he can have. See, I'm saying, I'm of the opinion that don't restrict in toto, but don't depend that, array maine protein bar roj lena hai, no. Try to have lot of variety, like 2 days in a week he will eat badam, 2 days he will eat singdana, 1 day egg, or and then maybe once on Saturday or something he can have one protein bar. That's okay.
Okay. Thank you so much, ma'am.
Yeah.
Any more questions?
Dr. Suryakant Sankhe wants to talk. Dr. Sankhe?
Yeah, wonderful lecture, madam. And I think your lectures are always induces us to use our gray cells. My question is, my question is, we add salt, which is iodized salt, but chemically when we add salt, which is the substance which is cooked or boiling, I think iodine get lost. And that is one of the concern, I think, many times after using proper iodized salts also, some of the patients are developing iodine deficiency. On that, what is your say? And second is what you said, that we have to respect and consider the working mothers and salute them. And in that, I have found that they are very adamant and they don't listen to our what typical advice we give about diet. So we have to change as a pediatrician, and we should be more, I think, considerate about mixing and matching the modern food, or we can say the some junk food also, whether it can be added to the normal diet and make it more acceptable to the mothers and child also. These are two questions I have got.
Yes. So one thing is there, iodine by and large, I was not aware whether iodine gets destroyed, but we can add salt at the end and then put the gas off. So that once we add the salt, we mix it, put the gas off, then the salt gets distributed. That would be really nice. Like how we do vitamin C, or how we squeeze lemon at the end. So that is something. Second thing, few common recipes, like, see, I also have, and especially mother from good, see, I was also a working mother, so we know the difficulties the working mother can face. So the time constraint is very important. And second part is whether the child also wants to eat what you cook. See, if I cook poha or traditional Indian breakfast, but then they want some other breakfast. So we have to accept. So pizza, what I can say, I've already told you how to enrich Maggi nutritionally rich. So for this one, pizza, we can always reduce the quantity of cheese, which we grate on the top. Second thing, what I make at home is I make bhakri pizza, where I make bhakri out of jowar, and then that I put the topping on it. And once you make it little on the slow gas, once you make it, by and large, they don't come to know. Best way is not to tell them that we have made bhakri pizza. This is homemade pizza and this is how it tastes. So this is something which we have to accept. And then apart from that, supposing if we are making pasta, it's the same thing. Where pasta, after boiling the pasta, I put usually lot of, we try to avoid ajinomoto or something in that pasta sauce and ajinomoto, but try to give little Indian taste to it by giving little carrots, French beans. So make it vegetarian pasta means multi veggie pasta. That's a better way. That's how I make it. So bruschetto also we make it accordingly. So little variation, I think we have to take lot of efforts to make it. But
Thank you, madam.
the
Jayashree, there is
easiest
a
way is very difficult. The mothers also want their own space or time. So it's not easy. That's what I told you. It's not easy to change. Though we advise, they'll go out and they'll ignore, out of the consulting room.
Another
Jayashree,
important, yeah, another
Jayashree, we have got
important.
Jayashree, we have got now one more madam has opened avenue. Why not have a competition of our pediatricians and prepare modern food for children,
That's
combination.
very good suggestion.
We
And
can have,
yeah, we can have online competition.
sure.
Yes, very good.
Thank you.
Okay. Right.
Another question I just want to ask, like there are phytates which are there in our green vegetables, and we mix them while eating. We eat like thali, and that actually hampers the absorption of proteins or other vitamins. So what we can do to reduce the phytate contents of that green vegetables?
See, very few green vegetables are eaten raw. One of them is methi. Second is this one, kandachi path. Kandachi path in that rice which is sprinkled. Usually they make that Shizwan rice, and that sprinkled kandachi path is raw. But otherwise, usually spinach has the largest amount of phytates which are there. So best way is to boil the spinach and then put it either at the form of spinach puri or something. That will make it low. Otherwise, eating little smaller amounts is okay. That is.
Now there is a lot of things going like the protein diet, or we should eat only proteins, no carbohydrates, or what is your take on that? Because
I know.
like
I am
carbohydrates
fighting
are the
with my
villain.
dietitian for that because I am
Hmm.
a diabetic. So she wants me to have grainless meal, only protein meal, and I am unable to accept that concept. Today afternoon also I had, but I feel as a balanced diet we require all four. The proteins, the carbohydrates, the fats, and vitamins and minerals. So I feel the proportion may be around 20 or 30%, with lot of, especially those who are weight losing diet, they go on chicken based diet and other things, and then that high protein. But ultimately when we need energy sparing effects, ultimately that protein will be used for producing energy. So I personally feel that grainless meal is not the concept which I will follow, but of course I need to read more on it. I've not thought about it, but I feel it will be used for producing energy, because energy building first, then comes the body building. So energy yielding, body building, and then comes the enzymes and the function. So all these three, if the first is energy yielding is only not met, then there is no point, and we are taxing unnecessary our kidneys. So I feel 20% maybe reduced from 40% to 20%, but carbohydrates have to be there. That's what I feel.
Another villain they say is the seed oil. So instead of seed oil, they ask about the like pure ghee, which has more butyrate. So what is your opinion?
Actually, those NIN guidelines, or they feel that we require both the saturated fats as well as the unsaturated fats. Means the uh, ghee is also required, and we require the oil also. So up to 5 grams of ghee is allowed in a day. And beyond 5 grams, we need to have the oil, which may be cottonseed oil. It may be, so we rotate the oil so that actually we get a equal combination of omega 3, omega 6, monounsaturated, polyunsaturated fatty acid, MUFA, PUFA, both that way. So up to 5 to 10 grams is allowed, because ultimately otherwise the liver will synthesize those cholesterol from the monounsaturated fatty acids. So it is allowed, the tradition custom. Means if you really read and go back, what we have been doing, our traditional Indian diet has got, and after eating also, that when are we supposed to drink water? Either in between the meals or 1 hour after the meal. That is also good, so that we get enough water. So that is something which is good.
Okay.
There are many questions now again, and we just want to learn from you many other things also. We will definitely call you, madam. Genevieve, you want to add something?
No, ma'am, the same thing. And one question was there, like madam तुम्ही explain केलं की 6 महिन्यापासून 8 महिन्यापर्यंत 3 meals आणि plus
2
breastfeeding.
to 3 plus
2 to 3.
breastfeeding.
But majority of these females they start working from this 6 months आणि त्याच्यात ते 12 तास नसतात, म्हणजे ट्रॅव्हलिंग वगैरे सगळं इन्क्लूड केलं तर. सो द डेफिसिट कॅलरीज जे राहतात, जे म्हणजे त्या मील्स मधून नाही येत आणि उरलेले जे आपण दुधातनं कन्सिडर करतो, मग त्याच्यासाठी त्यांना काय ऍडवाइस करायला पाहिजे?
Is it advisable for them to express the breast milk and give the express stored breast milk? Somebody from home can feed? Nothing like it. If they can't feed, then the breast milk has to be replaced by the milk-based diet.
Okay.
If mother can express the milk when she is at work, carry it home and keep it for the next day, nothing
That is
like it.
best. Yes.
That is the best option. So keeping express breast milk to be fed to the child when she leaves for work, that is the best option. But if she can't do it, then we have to give cow's milk. That is, we can't keep the child hungry.
Okay. थँक्यू सो मच मॅडम. आपण खूपच न्यूट्रिशन बद्दल आम्हाला सर्वांना अवेअर केलेलं आहे. मूव्हिंग फॉरवर्ड, आवर नेक्स्ट स्पीकर, I think madam needs no introduction. Our very own Dr. Anuradha Palwankar madam. Madam is practicing pediatrician. She practices in Abhinav Pediatric Hospital in Virar. And madam has an experience of over 24 years. Madam is very active member of Palghar Academy of Pediatrics, and she is currently serving as Secretary Palghar Academy of Pediatrics. She's going to talk about epidemiology. The future ahead, आपल्याला जे पण काही चेंजेस करायचे आहेत, जे पण नवीन गोष्टी आहेत, एपिडेमिओलॉजी आपल्याला रस्ता दाखवत असते. सो ओव्हर टू यू मॅडम, आपण एपिडेमिओलॉजी बद्दल बोलू शकता.
Thank you, Genevieve. Good evening, everyone. Today I'm going to discuss about every month we discuss Palghar epidemiology, and we discuss the cases we have seen in that month. So in my OPD, I'm seeing a lot of viral, definitely because of the monsoon, viral URTIs, LRTIs. Then some are getting admitted for prolonged with leukopenia and thrombocytopenia, and they're responding to anti-flu medicines, that is oseltamivir. And I'm seeing a lot of hand-foot-mouth disease in last month, which are responding to supportive line of treatment. But one child we had 2.5 years, she had severe oral ulcerations, and she got admitted for that because for 3 days she couldn't eat or drink anything. So we admitted the child for IV fluids, and two cases we saw of enteric fever. One was culture positive. She responded to ceftriaxone. She had fever of almost 14 to 16 days, and she responded on day 6 with ceftriaxone. She had very high fever, up to 104, and one spike was of 105, and she responded well to ceftriaxone on day 6. Because she had high fever on day 5, so we added with azithromycin, and she responded well. Otherwise, we are seeing neonatal hyperbilirubinemia because of warm environment.
असं टाचणी आहे का
babies are
शिवानी
getting admitted. Lot of babies are getting admitted for phototherapy.
असं
So I Dr. Joshi madam and Joshi sir, Dr. Sankhe sir to tell us about the cases they are seeing in their OPD. Dr. Sankhe sir. Joshi madam.
Yes, Anuradha, what you have said, similar picture is there in Palghar Boisar also. Of late, I'm seeing more of children, those who are, maybe I'm seeing less newborns nowadays. So age group 4 to 12, as enteric fever is on the rise, and viral fevers which are not typical viral fever, because fever goes on for 6 to 7 days, and it's a quite high grade fever, and they are tired, and all tests don't fit into enteric or any viral also, but they do respond to ceftriaxone on admission. If you give high dose of ceftriaxone, by second, third day, their fever starts responding and they start eating well. So I don't know whether we are missing them, because 6-7 day blood culture may come negative. So empirically, I consider them maybe enteric fever cases. And as you have said, neonatal jaundice is a subject where I think because of faulty feeding and environment, and I don't blame, but we have to be in association with our obstetrician friends. LSS rate is quite high, and almost for second or third day breastfeeding is not started. Or so I think we have to have a proper communication with them, give a proper feed, and keep baby hydrated, because within 12 hours with us, I think phototherapy bilirubin starts coming down. That means it is we have created the hyperbilirubinemia. It is not because of any disease. So that is my take for this one.
That's an important point, because we can have a combined Zoom meeting with all the gynecologists and pediatrician for this problem which we are facing. So that is a very good way. Thank you, Anuradha. And Genevieve, you want to add something about your own experience? Vaibhavi, you want to add? हेमंत जोशी सर, तुम्हाला सांगायचंय का काही? Genevieve, you are muted. You are mute.
Yeah. Madam,
Ah.
urticaria is also on rise. Like last month, there were many people, in my own family, my kids are allergic and they all had urticarial rashes and this conjunctival congestion and all. So that is also something which we are seeing in this season. I mean, is it everywhere or it is only specific to a particular location?
Every month, I think we see few cases of urticaria. Not specifically in this month. Last month I saw 4 cases of P. vivax malaria, and they all responded. 3 from similar family, labor class, and one was different, and all responded to oral chloroquine. And then I continued with primaquine for 14 days, and they responded well. But they got admitted because of vomiting, high-grade fever, thrombocytopenia and all. So, but
So
they
malaria
responded
has
to
a comeback.
oral chloroquine. But this month I have not seen any. These 4 patients were from Vasai Virar Municipal Corporation, Boeing. So, and lot of dengue also, but they are primary dengue. They are responding well to supportive line of treatment. Even in our IPD, we are admitting dengue with thrombocytopenia or high fever, but they are responding to supportive line of treatment.
Hello.
That's interesting. But
Hello.
malaria
Yes,
has a
madam.
comeback. Alka madam.
Have you are seeing Japanese encephalitis? Because Vashi, I'm seeing, I've got this is the second encephalitis with it's obviously a vector-borne, mosquito-borne illness. And I've seen one adolescent, one 80-year-old child who has come with encephalitis. And MRI is classical of involvement of the bilateral thalami and subcortical striate nuclei. So whether have you all are seeing it in the Palghar district also? Because I've seen this Japanese encephalitis for the first time. Maybe next time I will share with you, or maybe Jayashree, you can also show them the MRI picture of this Japanese child, Japanese encephalitis child. No, it is classical. The viral NIV viral reports are awaited. The child, the mortality is almost 50% with Japanese encephalitis, and that's the reason. But this child is fortunately doing well with acyclovir and. I mean, because it's acyclovir, and though there is no treatment, we are giving acyclovir along with steroids and mannitol.
That
So
is
it is
because of
being
the migrated population which we have nowadays. And I think if it is proved by NIV, we can like decide whether we have to give Japanese encephalitis vaccine to each
vaccine.
and everyone. Yeah.
Yeah.
We are recommending to people to give Japanese encephalitis vaccine. Some are giving, some are not giving. But
Cost?
because cost
much
is,
is the-
madam, cost is very less. I think 600, up to 600.
Up to 600. It's freely available. I have not given
MRP,
it.
it is freely available. MRP is around 800 to 1000, in between 800 to 1000. And it is a single dose, 0.5 ml IM. It is easily available, madam.
Okay.
So I'm recommending to all children. Some are giving, some are not giving.
Yeah. And Vashi, I've seen 3 cholera, 3 kids from the same child who came Vibrio cholera positive. That slide video also I'll share with Jayashree. So what is
Alka,
your
I
take
am
home for?
Dr.
I've
Alka.
seen cholera almost after 20 years.
Dr. Alka, we want you to join this webinar every month and have your expert opinion so that we will be learning many more cases from you. So please join every month. I will share you the webinar, and this is the same link which we have every month. Please join every month as an expert.
Yes, madam.
Yes.
Yeah. So Japanese encephalitis vaccine, I'll tell maybe nurses and all, they should at least tell everybody.
Yes, and it is cheaper, not very costly. Like
Not very
hepatitis
costly
B.
also.
Yeah, like hepatitis B, we can give to all the staff.
Yeah.
But we are
How
not
about-
seeing any cases.
No, you've not seen. But this MRI, now tomorrow when I go, I will photograph and send it to Jayashree.
Yes, madam. Yes.
Yeah.
So with this, this is a wrap on this knowledge bonanza which we have today. Thank you so much, Dr. Alka Jadhav, madam, for your elaborate and like detailed nutritional guidelines which you have shared with us. Thank you, Dr. Anuradha Palwankar, for the pediatric epidemiology which is there in our Vasai, Virar and Nalasopara and Palghar district as such. Thank you, Dr. Aditi Dandavate, for an unusual case which we have witnessed now. And thank you, Genevieve Tuscano, for the nice moderation. Thank you, Pallavi Dharmadikari, madam, for helping us in this for the smooth running of this webinar. And thank you all the audiences which is there to support our monthly CME. We will be having monthly CME every month with 1 MMC point granted, and thanks for this special efforts by Dr. Anuradha Palwankar, madam. Thank you, Dr. Hemant Joshi sir and Dr. Archana Joshi madam for the kind support which they always give to Palghar Academy of Pediatrics. Thank you so much.
And I want to tell all of you that few MBBS students have joined, almost 6 to 7, for this webinar, and they will be definitely gaining the knowledge from Madam Jadhav Madam.
Thank you so much. We can end this meeting. Thank you. Thank you.
Thank you.
मनापासून धन्यवाद. सरांना बोलायचंय. थांबा. हेमंत जोशी सर, तुम्ही सांगा.
I am observer, so I must observe something.
Yes, sir. हा.
We are grateful to Dr. Jayashree Madam. She has introduced self-defense to the whole of the country. We all should see that it is done in all our schools and periphery, and we all join this effort. आणि मॅडमकडे पुस्तक घ्या, त्याचे व्हिडिओज घ्या, आम्ही ते टाकूया लिंक करून. ते आपल्या स्टाफला शिकवा, शाळांमध्ये शिकवा. शुभेच्छा. थँक्यू.
थँक्यू सो मच सर. आणि हे सेल्फ डिफेन्सचं जे इनिशिएटिव्ह आहे, इट्स ऑल सपोर्टेड बाय डॉक्टर अर्चना जोशी आणि हेमंत जोशी सर. ते आमचे मेंटर आहेत या प्रोग्रामचे. सो थँक्यू सो मच सर. थँक्यू.
ते केलं नाही, आम्हाला भीती वाटते जयश्री मॅडमची. एकदम स्ट्रॉंग आहेत.
थँक्यू सर. Pallavi madam, you can end the meeting. Thank you, Genevieve. Thank you, Anuradha.
Thank you,
Thank you.